Okay, so the topic today is evidence-based treatments for couples with unexplained infertility, a guideline. So this is from the American Society of Reproductive Medicine, and these guys are great. They basically assemble the best of the world's experts. They put everybody together. They task them with coming up with a guideline that will explain what a specific topic is. It could be IVF, it could be male factor IVF, it could be genetic testing, PGT, mosaicism. And if you go through there, you'll see tons and tons of info on many different subjects, all of which I had to memorize last year for the big board exam. So it's a great resource. It's free. You can access it without even being a member. And they're readily available to you to look at and peruse. And some of it's pretty scientific, so you probably need some help getting through some bits. But they have these really nice summary statements. And what we're going to do tonight, for those of you on Facebook or on Twitter or YouTube, you're in the right place if you're on one of those ones, because I can share everything with you guys, and that way we can kind of go over it all together. So you should be seeing that now. And I'm going to start by just telling you what studies they included. For those of you on Instagram, we love you guys too. I do love Instagram, but unfortunately I can't show you everything, so you have to listen to me read briefly. So they included randomized controlled trials or systematic reviews or meta-analyses, or even other trials that at least had one comparison group. So that could be a cohort, a case control, a trial without randomization, anything like that. They made sure everybody was human, so there were no animal studies, because it's kind of hard to have unexplained infertility in animals. They made sure they were all English, which does eliminate some valuable research, in particular in French, German, things like that, where we do get some literature, but the majority, these ones were all English. The studies had to have a comparison group. They did allow early endometriosis or minimal endometriosis, so that's important as well for those of you that may have that. If there was ICSI involved, they made sure that there was at least a minimum sperm count, and they did make sure that these women were having regular ovulation. So this is not in relation to polycystic ovarian syndrome. That's really important to remember, because we're going to talk about meds we use for polycystic ovarian syndrome that we know work in that situation, but do not work for the patients with unexplained infertility. And then they also looked at pregnancy rates, live birth rates, so the studies had to have that as a primary or secondary outcome. And then they looked at studies that had gonadotropins, which are the injectable meds. There is a whole slew of things that they excluded. So steroid therapy, diagnostic rather than therapeutic studies, if they were testing your tubes as part of the actual study, if acupuncture was part of the treatment, if you were getting tamoxifen, if there was progesterone support. So there's some stuff that they excluded, including things like tubal factor, severe male factor. So there were some things in there that were really important that they excluded, and that was appropriate for this study because those people probably don't have unexplained infertility. So then they categorized their recommendations based on things like high quality evidence, intermediate quality evidence, and low. And then they had grade A, B, and C in terms of the strength of the evidence as well. Okay, so I actually asked on our Instagram account a couple of questions like, how many people think that unexplained IUI helps? And initially it was like 60% thought that IUI would help for unexplained infertility when it was just being used alone. And I also asked how many people had had letrozole for unexplained infertility alone. And again, initially it was about 62%. I think we ended up around 55% or so that had, in both categories or both questions, that had said that yes, they had had letrozole, and or yes, they believe that IUI alone without any medication was helpful for unexplained infertility. So this is really important because you guys are out there all the time. You're reading, you're learning, you're talking to your friends, you're in your chat groups, all of that stuff, and that's really important. But at the same time, there is a lot of misinformation out there, even from the physicians. And I know lots of physicians that have given patients medications that don't necessarily work. So that's what I wanted to review with you guys. So the first topic is does intrauterine insemination work with your natural cycle? So this is you just making your natural egg. Usually you'll produce one every month. If you're making your one egg and it's growing and releasing, is insemination alone going to be helpful? So they looked at 7 different randomized controlled trials, 1 cost effectiveness study, 6 cohort studies, and looked at the answer to this. And the answer is no. Insemination on its own is useless. So if you look down here, you'll see their summary statement. Their summary statement, for those of you on Instagram, says there is strong evidence that IUI in unstimulated cycles, so your natural egg, is less effective than ovarian stimulation with IUI, and it is not significantly more effective than expectant management. So expectant management gets you somewhere between 3.1 to 4.3% success, and doing IUI alone does not alter that. You're still in that same success range. So you're spending money, you're going through the emotional part of it, you got to go into the clinic, some places bring you in and test you and do all sorts of ovulation testing and so on, and looking with blood work and ultrasounds, and at the end of the day, they're not actually helping you. You're spending valuable money for nothing. So if you have unexplained infertility, should you be doing just IUI without any pills? No, you should not. Now, if you have cervical factor, you've got male factor, those are all different issues. But if you don't have any of those, you're purely unexplained, they've explored you for everything, they can't find a reason, do not do just IUI. It will not work. And so their recommendation is it is not recommended to perform IUI in natural cycles for the treatment of unexplained infertility. It's less effective than taking stimulation with IUI and no more effective than just waiting and having sex. So you could do that for free. So the next question is, what about Clomid, clomiphene citrate? So for those of you in Canada, it's hard to get Clomid. You have to have it custom compounded now. I believe it's still available in the US, which makes it a little easier to get. For a lot of us, it was supplanted by letrozole because we use these drugs mainly in our PCOS population, and letrozole is actually better than Clomid in the PCO population, so we often use letrozole more now. But for this particular part of the study, they just looked at the Clomid. So this one included 4 randomized controlled trials, 3 systematic reviews of randomized controlled trials, and they all, again, showed the exact same thing, which is there is good evidence that clomiphene citrate with timed intercourse, so this is just Clomid, you're not having an IUI, is no more effective than expectant management. So they said it is not more effective and therefore it is not recommended. So I see this all the time. You've gone to your family doc, you have not done adequate testing probably, or even if they have done adequate testing, they say, you know what, here, take some Clomid for a little while, and then people try it and they come in saying, well, I took Clomid, why didn't it work? Well, the reason is if you have unexplained infertility, it's not gonna work. It's no better than expectant. That doesn't mean you can't get pregnant during that time period. You may well get pregnant, 3.1 to 4.3% do, but it has nothing to do with the Clomid, it's just pure luck. So the next one is the aromatase inhibitors, which is letrozole, so we were just talking about that. Same thing here. There is good evidence that letrozole with timed intercourse is no more effective than clomiphene citrate with timed intercourse, which is not effective, or expectant management. So again, if you're taking the oral medications, Clomid or letrozole, and that's the only thing you're doing, you're not doing it with insemination, you're actually not doing anything of any value. So that does not help you at all. It is not useful and you're not going anywhere, so you're spending money on meds, which do have some side effects, granted not a lot, but it's not doing anything for you. So the next grouping is, well, what about the shots? The shots are stronger, right? Everybody says, yeah, the shots are stronger. I'm spending all this money. This has got to be good. Well, it gets a little bit more dicey here. So the problem with the shots is they've included 4 randomized trials, 1 systematic review, and 3 cohort studies to see if it worked or not. And the answer from all of this was, if you're just taking the shots and having sex, you're not doing insemination. They say that there's insufficient evidence to determine if it's beneficial or not, but they say that there's moderate evidence that the treatment outcomes, pregnancy rates, miscarriage rates, and so on, are essentially similar to what you get from just taking the oral medications with timed intercourse, So that's, again, not helpful because we just reviewed that. And they said most studies report no difference in pregnancy outcomes if you're taking gonadotropins, the shots, versus just taking the pills, with a slightly higher rate within that same pregnancy rate of having twins or triplets. So that's a problem, because if we are going to get you pregnant, we really are trying very hard to get you pregnant with just one baby at a time, because it's much, much safer for you guys. So again, their recommendation, not recommended to use shots with timed intercourse. I don't think I've ever done that before. In the treatment of unexplained, studies report either no difference in pregnancy outcomes compared with oral stimulation agents, or higher pregnancy rates associated with a higher risk of multiple gestations. So dangerous in some extent and probably not beneficial. Okay, well, Clomid alone, letrozole alone, shots alone doesn't work. IUI alone doesn't work. Well, what if we combine those things? What if we do pills with shot or with insemination? Does that help? So it does. If you look at ovarian stimulation with Clomid, and you're doing insemination with that, if I can get this computer to cooperate, here we go. So summary statement for that, and there's lots of studies of this, okay? There is strong evidence, so these are lots of good studies behind this, that Clomid with IUI is superior to expectant management and natural cycle IUI for the outcome of live birth. So the holy grail I always talk about is the live birth rate. Live birth rate is higher with Clomid and IUI versus just expectant management, or just taking IUI or just taking Clomid. Multiple gestation pregnancy rates with clomiphene citrate and IUI range from 0 to 12.5%. We normally quote 8. And there are very little differences overall in terms of the outcomes. There were huge numbers of studies involved in this. They did also compare between letrozole and IUI versus Clomid and IUI. They basically said that there were no significant differences, although they said maybe there's a little bit of a higher success rate with letrozole and IUI than with Clomid and IUI. So bottom line is good, strong evidence that if you combine the two, now you're seeing a higher success rate. What kind of success rates are we talking about? Over 6 months of use, anywhere from like lows of, obviously 0 if it wasn't working, to as high as about a cumulative rate of 30%. So you got to be prepared for the fact that this is not a guarantee. There are lots of people that still need further therapy, but at least you have a better chance starting off. And in 1 or 2 studies, the rates were getting as high as like 40–45%. So reasonable to try this, reasonably cost effective as well. No harm done, and so it's completely reasonable to do this. So what about letrozole with IUI? They did study it separately. They also say here there is strong evidence that there is no significant difference in pregnancy rates or multiple gestation pregnancy rate following letrozole with IUI as compared to Clomid and IUI. So we know Clomid and IUI is good, and it does work. On average per cycle, you're going to get around an 8% success. So with letrozole and IUI, it's the same outcome in terms of success rate. It's the same outcome in terms of twins. I've never seen triplets on letrozole. I'm sure somebody has. So keep that in mind as well. Okay, what about IUI with combinations of Clomid and the shots, or letrozole and the shots, right? So does that help you? Maybe you need that extra little bit of push. So it is a higher success rate. So they say there is fair evidence that clomiphene citrate and the conventional dose, so normal dose gonadotropins with IUI, so you're taking Clomid, you're taking the shots, and you're doing an insemination, have higher pregnancy rates than expectant management. They say that there's good evidence that that combination is increasing your risk of multiples, and there is actually good evidence that the clinical pregnancy rate and live birth rate are actually similar when comparing letrozole and low-dose gonadotropins with IUI versus clomiphene citrate and low-dose gonadotropins. So if you try and take letrozole versus Clomid with the shots and IUI, you're going to get the same outcome. So they say that you don't really need to do it because you're not getting a much better success rate than you are with just Clomid or letrozole, but you are increasing the risk of multiple gestation. Now here's one place where it's a little confusing, because they do say that the success rate of getting pregnant is higher, but they're kind of putting a downplay on it because they don't want you to get pregnant with multiples, which is also higher. So you got to take this with a grain of salt. If you need that extra push because you've been trying for a long time, this is a reasonable approach. You just have to be prepared for the fact that you may end up with more than one little critter inside there. What about IUI with just low dose shots? So that's up at the top here on the page. So if you're taking a low dose, which traditionally is less than 150 units a day of Puregon or Gonalef or Menopur, whatever your drug of choice is for your clinic and your physician. So they've got lots of studies on this as well. And the summary statement, again, insufficient evidence that treatment with low dose gonadotropins with IUI gives you a higher pregnancy rate than the Clomid or the letrozole. So you're taking shots, which is uncomfortable for sure. You're getting way more hassle. You definitely need monitoring. You can't take shots without getting ultrasounds and blood tests. And actually, it does not show a significant difference in outcomes. However, they do say that the cancellation protocols, the study populations may be responsible for why they're seeing not a huge difference. There may actually be a difference there, but because they were so strict about who they would cancel, like for example, more than 2 or 3 eggs at a time, you weren't getting as much of a difference. So they said if your outcome prognosis is good or intermediate, you should skip the low dose because over 6 months, it was the same as expectant management. I'm not quite sure how you're supposed to figure out if their prognosis is good when they've got unexplained infertility. No one really explains that in this study. What about conventional dose gonadotropins? This is taking more than 150. I'm not quite sure who would do that. You've got to be either older or a bit heavier in order to justify a higher dose of gonadotropins than 150. We typically don't even go up to 150 for our IUIs unless your ovaries are weak, you have diminished ovarian reserve, your body mass index is elevated, you've had previous failures, that kind of thing, or age is a factor. So if you're 37, 38, 39, you can afford to have 3 or 4 eggs at that point because the chances of twins and triplets is lower and your success rate needs to be a little bit higher as well. So all of those are kind of critical elements to factor in, right? So what did they say for this one? Same thing, insufficient evidence that this is a higher pregnancy rate than just taking the oral meds with IUI. So in other words, you're spending all that money on higher dose shots now, even more money than you were with the lower dose ones, and they're saying that it may not be beneficial. Again, they put in that sort of disclaimer where they say it may be because of different study types and different investigation questions and different patient populations and cancellation criteria. So again, I do suspect it is stronger, and there are studies that have shown that it's stronger and that your results are going to be a higher success rate, but they're worried because nobody wants you to have twins and triplets, and it is uncontrolled when you're doing IUI. Okay, what about the timing of the intrauterine insemination? Some people do 0 hours, 12 hours, 24 hours, 36 hours, and then there's that whole pool of should we do a double IUI? And the answer is if you're doing it anytime between 0 to 36 hours, it's the same, although there is one study that says that 36 is better than 24. So we traditionally choose 36 and most places do. There is good evidence that a single IUI is the same as a double IUI. The only time it may be beneficial is if you have very low sperm count, so then maybe a double IUI would be better. And they actually go so far as to say, and we've explained this on the show before, that monitoring when you're just taking something like Clomid and doing IUI or letrozole and IUI, doing the LH monitoring or ultrasound monitoring is not necessary. There's no evidence that shows that that improves anything in terms of timing compared to just using an LH kit. So you can send these patients home, wait for the natural surge, take a trigger shot to improve your success rate, and then go ahead and do your IUI 36 hours later or 24 hours later in those cases, which is what we do, and you'll get a very good success rate with that. Okay, what about IVF? Well, IVF is definitely the best treatment for unexplained infertility, as it is for almost everything. However, they say current evidence does not support IVF as a first-line therapy. So you do not need to jump into this, which is what a lot of places are doing. So you show up, you say, wow, we've been trying everything. They go, okay, let's investigate you. They investigate you. They say, look, you've got unexplained infertility. You should do IVF. Well, actually, you don't need to do IVF because you got a, as high as 30, maybe even 40% chance doing the pills, super simple with IUI, super simple, way more cost effective. And if we don't have to do IVF on you, legitimately the only reason to do it in that scenario is to make money, and that's not the right reason. That's totally immoral as far as I'm concerned. So really you don't need that as your first line therapy. I strongly support this statement. Should it be used in older women? Yes. If your ovaries are getting weaker, that's a different story, because using up 6 months of time for something with a lower success rate is very different from younger women with unexplained infertility. And they say that here as well. Good evidence that in immediate IVF in women greater than or equal to 38 years of age may be associated with a higher pregnancy rate and shorter time to pregnancy compared to a strategy consisting of the oral medications for stimulation with the IUI treatments, or even taking the shots with IUI treatments. So make sure that you factor in everything about you. If your ovaries are weaker, if your age is an important issue, you got to put that into the equation before you decide what to do. So that's really important too. So that's the whole total of the things that they looked at. Now, the one thing they didn't look at is surgery. We do talk about that a lot on the show. It is one of the alternative options. And if you have unexplained infertility and it wasn't in the day and age of COVID, it would be very reasonable and rational to consider doing something surgical to evaluate to see if you potentially have endometriosis. Because if you do have endometriosis, that definitely makes it a lot harder to get pregnant. And those patients really need extra care, extra evaluation, possibly extra treatments, because you're no longer unexplained. You've got tubal damage, you've got scarring, you've got inflammation, you've got hormonal changes, inflammatory changes, and all of those things can be contributing to your infertility. So knowing if you have endo, tubal damage, scarring, anything like that can be a huge issue moving forward through all of these important decisions that you make. So I do believe in surgery for unexplained infertility. There is some data that demonstrates that it is helpful, and certainly if you have mild or moderate endo, treating it does improve your success. So we've had loads of that where I operate on patients, find out they have endo, you clear up the endo, and they get pregnant without needing any therapy. So that's a really good option for patients too. Problem right now, at least in Canada, it's virtually impossible to get you into an operating room. So you're kind of back to square one. So we didn't really totally have a fact or fiction this week because there were so many different topics, but the fact and the fictions are that if you're taking either Clomid alone, letrozole alone, IUI alone, or shots alone, there is no benefit over just trying by yourselves without any kind of therapy. It's not until you start combining the pills with IUI, the pills and shots with IUI or IVF or surgery, that you're actually doing something productive for unexplained infertility. So make sure if you do actually have a diagnosis of unexplained infertility, and that really needs to be determined by an REI, a fertility specialist, that you're not just getting pills and going home. It's not gonna work, guys. And if you're trying to save money, you're actually wasting time by avoiding the IUI, which is a necessary component of your success. Okay, so thanks for joining us for that portion of the show. As always, like, comment, subscribe on the YouTube channel. We want to get people to view this. This is a really important topic, and hopefully lots of people will pay attention to it so that they're saving themselves time, money, stress, a lot of expended effort for nothing in many, many cases.